This week on Cold Steel.
We wouldn't think in America of letting anybody but a board-certified general surgeon take out an appendix, but that wasn't the way it was in the 1950s, and it's not the way it is in these remote places in Canada. And I think that our standards should be just really looked at. You know, what do we really need someone to be skilled in to be able to do that job?
Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Dr. Mark Campbell is a practicing general surgeon in Texas and a retired NASA flight surgeon. He has been researching space medicine for over 2 decades. In this episode, we talk to him about prophylactic surgery for astronauts, what it would take to develop remote surgical space capacity, and telementored ultrasound. Dr. Campbell, thank you so much for joining us on the podcast. We wanted to start out by asking you, what drove you into getting into space medicine?
It is kind of, I think, an interesting story. I was, brought up like a lot of kids with the American space program, and I was 14 when the Apollo 11 landed, and was very interested in space, but really didn't think that there was any realistic way that I could be involved as an adult, and so. My interest turned to medicine, and I became a general surgeon. And then in about 1987, I went to a meeting, and the speaker was Norm Thagard, who was an MD astronaut. And he gave a talk on space medicine. And I didn't know there was even such a thing as space medicine. I was very ignorant about space medicine and space physiology, but I got very excited about that, and he encouraged me to become involved in space medicine. And so, that's when I joined the Aerospace Medical Association, the space medicine branch, and started reading the literature and just getting smart on space medicine. And then I really started thinking a lot about, how would you do surgery in space? Every time I did anything, I really kind of put the application of how would I do this, in space. So I just started thinking about it a whole lot, and I came up with some ideas on some projects, and to me the big issues were bleeding in space and how to restrain the patient and the surgeon and the instruments. And so I presented my ideas to Roger Billica, who at the time was the director of the Health Maintenance Facility Project for Space Station Freedom. And so he was a very good mentor to me and allowed me to start doing some projects. And I had really no funding for these projects, so I kind of had to give it my own time and my own money. But I went forward with it, and we did initially some small animal studies and then some larger animal studies in parabolic flight, and really looking at those questions, bleeding in space and how to restrain everybody for a surgical procedure. And then also, some other things that we got into like laparoscopy and thoracoscopy and things like that. And so I did a lot of this consultant parabolic research, and because I'd gone to Russia for about 3 weeks in 1990, and I had taken Russian in college, so I did have some Russian abilities. And in 1994, when we signed the U.S.-Russian Space Cooperative Pact, then all of a sudden, NASA needed anybody who knew anything about Russia or the Russian language, and there just weren't that many people out there. So I find a niche for myself, and with Roger's help, I was able to become get into flight operations, become a NASA flight surgeon, and was deployed to Russia. And the first time I was deployed to Russia, in fact, the very first day, it was to be sort of the backup flight surgeon to Norm Packard, who was the person who gave the talk in 1987. So in 1994, I went over to Star City and supported his launch, and got to meet him again for the first time since 1987. But kind of came around full swing.
Wow.
So that's kind of how I got involved. It's kind of a weird thing.
Well, that's so interesting. I've had the pleasure of parabolic flight with you, and of course our partner here, Andy Kirkpatrick, and you go way back. I was curious if for our listeners you could describe what that experience is like in zero gravity in any of the planes, really that you've been in or that we continue to use, and just to give us a sense, or give the collective a sense of how that feels and how you set up for it and what your thoughts are.
Mm-hmm. Well, and I did about 40 or 50 parabolic missions, but the main thing is it is a very artificial environment. You just have this maybe 30-second window of weightlessness, followed then by a 2G pullout, and so you have to realize that you do have some limitations. And then if you're using a artificial model like a mannequin, then there's another artificial variable added to that as well. I think that using a real animal model makes a huge difference. Just about everything that we predicted that would happen in weightlessness, when we got up there, it didn't happen the way we thought it would. And at first, our first reaction was that we set the experiment up wrong. We weren't able to show what we wanted to show, so it was our fault. The way we accept the experiment was flawed. But then with a little more knowledge and experience, we realized that our hypothesis of how things work in weightlessness was absolutely wrong. And we could never have found that out without using an animal model. So I think that was very important to use an animal model. You have to really tightly script everything for parabolic flight and say, in this parabola, we're going to do such and such, and during the 2G pullout, we're going to reconfigure, and then we're going to demonstrate, another aspect, and then we're going to reconfigure. And you have to have it very tightly scripted and very well practiced in your mind what you're going to do, because when you get up in parabolic flight, things happen very fast. And the more prepared you are, the more likely you'll have success with your project. And we had some very successful projects, but we really prepared. We did ground simulations and we did a lot of just script writing to prepare for those parabolic flights. And I think that's what made it successful. We thought that bleeding would be a problem in weightlessness, and it wasn't, because the surface tension forces, which we had no idea how predominant they would be, are really very predominant and keep you from having a problem with fluids. And then we thought restraint would be very, very difficult, and we had a lot of really elaborate ways to restrain ourselves and the animal and all of our instruments. We found out is really a lot more simple, especially if we planned for it and had a method. It was a lot more simple than we thought it would be. And then, laparoscopy, we thought we would not have very good visualization when we did laparoscopy, and it turns out that we had very good visualization, but for reasons we couldn't have predicted, and that is that the mesentery pulls all the bowel out of the pelvis, and it allows you to be able to visualize things. We also found that fluid in the chest acts completely different than we would have expected. It doesn't layer out at all, and it kind of sticks to every surface that it can, and so it doesn't localize. It just kind of becomes very diffuse. And so all these things were kind of unpredicted, and we had to learn them by going into parabolic flight.
Dr. Campbell, I'm listening to you talk about this. It's clear that none of the things that you, like a layperson or anybody, any average surgeon thinking about doing surgery in space would have ever really predicted. Can you to walk us through how the sort of the concept of doing surgery in space has developed over time, and where we sort of sit in terms of being able to do surgery in space now, given all the work that you have done on this, and then maybe touch a bit about where you think surgery in space is going in the future.
Yeah, well, I would put it. Let's talk about the different environments a little bit. Now, the International Space Station has like a 24-hour time to definitive medical care back on Earth, and so all the medical care system is really oriented towards stabilization and transport, as it should be. So there's very little surgical capability among the crew medical officers or even the equipment. Now, the two criticisms I have about the International Space Station medical system is, one, they'd have no provision for putting in a chest tube. And I really think that that's something that can be easily trained and easily provided for from an equipment standpoint, and would be life-saving if you ever needed it. And then the other thing is, there's no organized way to perform even a simple surgical procedure like a laceration closure. All the surgical instruments are individually wrapped, and so you don't have a surgical kit or a method to take all those surgical instruments, even a simple way, and restrain them so that they're organized and can remain sterile and can remain not only restrained but accessible. And it'd be real simple to have just a minor surgical kit that, and we did this in parabolic flight quite a bit, that you can just take out, and has Velcro in the back, and you can stick it to a wall, and it keeps your instruments organized and sterile, and it really makes a minor surgical procedure, like, say, laceration closure, a lot more simple. And so I think that was one thing that they should have had on the International Space Station, and I never could get them to accept it. I think it'll be very interesting if we go back to a moon landing, because we have about 200 pounds of medical equipment on the International Space Station. We even have an ultrasound. But when we go to landing on the moon, our medical equipment is going to be very, very, very small. I think we'd be lucky if we get 20 pounds of medical equipment. And so when you're on the moon, you're obviously in a much more remote place than the International Space Station, and your time back to definitive medical care on the Earth is going to be quite long, probably 3 or 4 days. So I think we're kind of going to, by necessity, box ourselves into a corner when we go to a moon landing. A lot less capability and a lot more risk, because our time back to Earth will be longer. So I think it'll be very interesting. Our risk will definitely be higher there. When you talk about going to Mars, and we've been talking about this for 30 years, like about every 5 years, we have someone comes up with some sort of conference about surgical care on a long duration mission, and I go to every single one of these. I've been to about 6 or 7 of them now, and everybody who is in attendance always feels like, well, this is just a really new thing. No one's ever talked about this before, but we do it about every 5 years. But we always talk about the same issues, but the knowledge base and the dialogue and the conversation is much more sophisticated every time we meet. And I think that one thing that becomes clear to me is that we don't need something real sophisticated and elaborate like robotic surgery or even laparoscopic surgery on a long-duration mission such as a Mars mission. What we need, though, is to have somebody who is surgically capable to be able to perform a variety of fairly simple surgical procedures. I think the paradigm to me is the general practitioner of the 1950s, because that general practitioner had very minimal surgical training, but he was able to do appendectomies, they did hernia repairs, they took out gallbladders, they did all kinds of stuff. And that's kind of what I think the crew medical officer on a Mars mission will need to be. He needs to be a general practitioner with some surgical training to perform some fairly simple minor procedures. And I think a big part of that medical care system is going to be percutaneous things, drainage, stenting, things like that. And so I think ultrasound-directed percutaneous procedures are going to be a real big part of that. But I don't think you need a lot of sophisticated elaborate equipment. I think you need a knife, a hemostat, some scissors, some suture. I think you can do everything with a fairly minimal set of equipment. I think it's also 3D printing is very exciting, and that you can just actually print your surgical instruments as you need them. Although people get excited about 3D printing, I like to point out to them the 3D printing now is still very low resolution, and so you get very crude, imprecise instruments that are not, I would not consider them good enough quality to perform surgery with. They're more like the plastic suture removal sets that you get up on the floor that they buy from the lowest bidder. You know, you can barely take out a suture with them. They're so crude. And it's kind of that kind of quality. But I think it's obvious that the quality is going to get better over the next few years. We'll get higher resolution instruments out of 3D printing, and they'll have material that's much more hard instead of soft like they have now. So I think it'll get better, and I think it'll be a big adjunct.
There's just degrees of remoteness when we're thinking about concepts like space, but I think that this applies even down on Earth as well too. And so I'm curious how you envision the operating room to look in space, or if you do envision a scenario like that. And then the second part of that is I'm curious about what you think we could do to apply that type of thinking in remote locations on Earth.
Well, we've looked at remote medical care on Earth as an analog to a long-duration space flight. And the two things we've been most interested in is the Antarctic experience and the U.S. Navy submarine experience. When a U.S. Navy submarine, those boomers go up underneath the Arctic ice, and that's where they sit, in case they're needed. And they are 3 weeks away from definitive medical care. It takes them 3 weeks to get out of that ice pack and get to a position where a helicopter could do a medical evacuation. So they're fairly remote, and they take care of a lot of things with just a independent duty corpsman. They've been treating appendicitis non-operatively for a long time, and when we wrote our article back in I think it was 2004 about the non-operative treatment for appendicitis, it was really a new idea. No one had really talked about that before, but the U.S. Navy had been doing it since World War II. Since that time, the non-operative treatment of appendicitis, tons have been written about it, and everybody's gotten real involved with it in the last 5 years. And so we have a lot more experience with it. But it definitely is especially if you think about being on a space mission. If someone develops appendicitis, we're going to diagnose it very, very early. It won't be somebody that's been sitting out there for several days, like we often see on Earth. We'll diagnose it very early, and we'll have fairly early intervention as far as, IV antibiotics, and our success rate should be very high, should be 95%, something like that. I still think we need to have the surgical capability to do an appendectomy, just simply because we need the surgical capability to do a lot of things, not just appendicitis actually has a fairly low incidence in the astronaut population. But we need to be able to do a whole lot of other things. And I think if you can just take someone and give them 6 months of very focused surgical training, I think they can do everything that needs to be done from a surgical standpoint on a long duration mission. We looked at Antarctica too, and they have a lot of success with dealing with appendicitis non-operatively, and so I think those things serve as analogs for long duration space mission, and they've given us a lot more confidence in what we will actually see and how we can take care of it. And I think it makes us feel like that we can take care of things a lot easier than we think.
Dr. Campbell, you mentioned your Journal of American College of Surgeons paper from 2004, and that's on our must-read list for all the interns and junior residents that come into the program here. It's a superb and really out-of-the-box review, so I encourage all of our listeners to check that out. I just want to swing back to the training a little bit, and although there's not many countries in the world that still do this, Canada is one of them, or at least some of our provinces. Alberta, British Columbia, and Quebec in particular have programs that take quite remote general practitioners in a real rural setting and are able to train them for 6 to 12 months for some of these basic surgical interventions, including percutaneous drainage, including remote telementored ultrasound like you and Scott Lachowski and others have proven so effective. And, they end up in places, not even Whitehorse, but much more remote to that. And they provide really impressive levels of care with quite often significant autonomy. And, whenever I see that and one of those folks comes through, I always do think that probably you're right. I mean, it's probably the model for the longer duration space flight, whether that's, to the moon or maybe even Mars one day for sure.
Right. I certainly don't think you need a board-certified surgeon or even someone who's been through a surgical residency to be your crew medical officer. You need someone who can take care of a lot of different medical situations, and I really think that Canada, it would be a great analog for deep space missions, because it's that kind of physician that we need, someone who can monitor psychiatric well-being, to be able to take care of medical situations, to make medical diagnoses. And then if you need to do something real simple surgically, like drain an abscess or even take out an appendix, you don't have to have a lot of surgical training or surgical skills to be able to do that. We think we do nowadays because we're just used to. We wouldn't think in America of letting anybody but a board-certified general surgeon take out an appendix. But that wasn't the way it was in the 1950s, and it's not the way it is in these remote places in Canada. And I think that our standards should be just really looked at. What do we really need someone to be skilled in to be able to do that job?
Mm-hmm. No, for sure. I completely agree with you. Another interesting topic is the concept of risk mitigation, and where surgical rescue plays into that and where palliation plays into that as well. It's always a bit of a sensitive topic, but from an outsider's observation, NASA and the Canadian Space Agency and other groups have been a bit of a pendulum back and forth depending on the particular mission and goals, for sure, and probably appropriately so. I think back to the crew return vehicle or crew rescue vehicle, the CRV, that NASA shelved in addition to some other things. How does that conversation usually happen with regard to, again, mitigation of risk versus therapy versus palliation?
Well, for one thing, I think that for every mission is different, and you need to know what capabilities you need to have for each mission. It has to do with mission duration and also time to definitive medical care back to Earth. It also has to do with what is your level of crew medical officer training. I mean, for the International Space Station, they get something like 40 hours of training. It's not very much at all. Mm-hmm. And also, what kind of equipment do you have? And so you shouldn't expect someone to to be able to treat a surgical disease if they don't have the training or the equipment. And I've always said also you shouldn't put equipment up there if the crew medical officer isn't trained to use it, because then that puts him in an awful spot. So beforehand, if you take, let's say, a lunar landing mission, I think you have to draw up and have a dialogue about what are your capabilities, what can you do, and what can you not do, and that way, when that happens, you can say, we don't have the capability to do this. We don't have the equipment. We don't have the crew medical officer training. It's just not something we're capable of, and so we're not going to attempt to do it. We'll mitigate it as best we can, but we're not going to be able to take care of it. And to make sure that you have a capabilities and a no capabilities list that's been well thought out for each mission, for each situation.
Yeah, no, that's very well said.
Going way back, to the old days when I first started consulting for Space Station Freedom, one of the things that they had on their capability list for Space Station Freedom. Now, you had to realize Freedom was going to be up there with no ability to return somebody on a medical evacuation for 45 days. So they had a 45-day definitive medical care time. There was no shuttle, no assured crew return vehicle. You were just stuck on the space station for 45 days without a shuttle. And so they had a lot of capabilities. And one of the capabilities they had was if someone developed a head injury, of being able to drill a burr hole and drain a subdural hematoma. And I thought that was ludicrous. And that was the first thing I threw out. I said, you get rid of the drill for the burr hole. We're not going to drill a burr hole on the Space Station Freedom. And they had all sorts of things like that with a little bit of thought, it was pretty easy to change that no capability list.
Well, it's such an important point, right? And it's something that we forget sometimes, down on Earth. It's sort of like opening the chest in the emergency department, maybe as an emerge doc. You kind of have one or two moves, and after that, what do you do? So there's a hole in the head, and then what do you do? It's still an issue. I was wondering if you could talk to us a little bit about some of the remote telementoring that you've been involved with, and of course our partner here, Andy Kirkpatrick, as a Canadian lead, and then Scott Blachowski as well. It's remarkable how transferable that skill and that communication can be from untrained person to untrained person, and really what they can get done.
I think the biggest thing that we do not know about, that we don't have experience at, is doing remote telementoring. And I think we need to try to get more experience of that. And I think that's a very low budget thing that can be done. Mm-hmm. And I wish that people would get more interested in it. You put somebody, doesn't have to be 100 miles away. He could be in the next room, as long as your communication back and forth is as if you were on a long duration mission. In other words, you have a time delay of, let's say, 5 minutes or even 10 minutes or a fairly significant time delay, and you try to talk somebody through, someone who does have some very minimal but basic surgical skills, but is not a surgeon, and you have someone who is a surgeon, try to talk them through something like, say, an appendectomy or drain an abscess or just some simple surgical problem, but with that time delay and with someone who really truly has very minimal training. And I think we need to get a lot more experience of that. And I think it has a real world application, just as you say, in remote places in Canada, to do some surgical telementoring in remote places in Canada. But of course, it has even more application with a future long duration space flight. But it seems to me like that would be a fairly easy exercise to do, to get experience at. because I think there's a lot of things we don't know about how you do that.
Mm-hmm. Yeah, I mean, certainly, again, we're biased up here, but Andy's really tried to push the envelope and done some really neat things in the past 5 years or so. Mm-hmm. To be honest, though, the place that I've seen sort of remote mentoring or telementoring in the world in terms of visiting and visiting professor and sort of experiences like that has been Australia. Their same thing. Their northern regions are incredibly supported by big cities. Such as Brisbane and Sydney. I mean, they have cameras in trauma bays, they have ultrasounds, and they don't obviously have to deal with the long time delays that you guys do, but what they can get done again, and the quality of care and the quality of teaching and the effectiveness at the other end is remarkable.
I think that's a skill set that we really haven't developed yet, and we're probably have a lot of ignorance in, is how you telementor somebody remotely, even without a time delay. Mm-hmm. How do you talk to things? How do you talk to them? How they talk to you? Do you have stop points where you kind of try to reorganize things? So I think there's a lot to be learned there. That to me, I see that a lot of research needs to be done in the next 5 or 10 years that will really open up that whole world.
Yeah, for sure. My sense is that it's coming. It's coming slowly. I mean, one of the interesting anecdotes, at least in Canada, is Andy ran it, and then I ran it, and we handed it off to one of our partners, Paul Macbeth, when he came and joined us as a trauma surgeon here in Calgary. And it was the National Ultrasound, Extended Fast and Beyond course, basically the American College course. And the demand for that course has almost gone to zero now, because ultrasound training is so ingrained in so many different types of residencies. So I'm hopeful that what you're describing will happen, and that interest will continue to increase. I'm just curious, as a penultimate question, how does all of this work and the deep thinking about surgery and surgical care, maybe more broadly in such remote environments, how does it inform your daily practice and the way you think with your patients, or does it at all?
I think it affects it in how I pass on information to other team members. I think a lot of times when you are discussing medical issues, surgical issues, especially trauma care with other team members, you assume that they know A, B, and C, and you find out very quickly that they may not know that you may have to dial back and become even more basic. You have to be very careful about assuming what somebody's knowledge base is or what their skill set is. And so you kind of have to be able to figure that out as you go along and be able to communicate effectively to make sure that you know what their knowledge base is, you know what their skill set is. And everybody tries to do the best job they can, and a lot of times they try to do things that they're not really capable of, or maybe don't have a skill set for, but they don't want to speak up and tell you that. And so you kind of have to very judiciously monitor them and make sure that they're not getting out of their league. I think about that a lot when I think about trying to do telementoring from a remote distance. You can't assume that you can't give them capabilities that they may not have. You kind of have to figure out what their capabilities are and factor that into the situation.
Dr. Campbell, for any residents or trainees who are interested in getting involved in space medicine or space surgery, what would you recommend in terms of getting involved?
Right. Well, that was the same thing as when I first got involved with this. Is that you have to get involved with the professional medical organization, which is the Aerospace Medical Association and the Space Medicine Association. And you have to start trying to develop relationships with people who are in the field and try to connect with them as best you can. Of course, the way you do that most of the time is by going through the annual meetings, and you just need to just become familiar with the literature. There's a set of literature out there for space medicine, a set of literature for surgical care in space, and just become familiar with all of that literature and what the issues are and what issues have been solved and what issues are remaining. And that's number one. Now, you have to realize that the research opportunities are very thin. There's not much money for research, and it's going to be probably less as time goes on, especially with the U.S. Debt being so high after the coronavirus event. And so I think that the federal budget is going to be very, very skimpy, and I think research money is going to be very, very minimal. So there's not a lot of opportunity, and you just kind of have to be as knowledgeable as you can, and then try to seek opportunity wherever it is.
It's hard to see anything without the word COVID in it getting a lot of play in the next little while.
Right. Well, we just added $6 trillion to the debt. I don't think they're going to be springing a lot of money for space exploration or space medicine.
Yeah. I also, while we have you, I wanted to ask about your work on prophylactic surgery for astronauts. Where do the space agencies really stand in terms of prophylactic surgeries for astronauts going on extended duration missions?
Well, I think it's something that everybody likes to talk about and discuss about, and we've been discussing it for 20 or 30 years. My own feeling is you take a specific surgical disease, let's say appendicitis, the incidence of that disease is actually going to be fairly low. And so by doing a prophylactic procedure, you've eliminated the possibility of having that disease. But it's such low incidence, you really haven't changed things very much. And I still think that you ought to try to be capable, surgically capable, of taking care of many things as you possibly can. Not just one thing, but just a lot of things in general. So you take appendicitis, and if you do an appendectomy prophylactically, you've eliminated that risk, but the incidence is very, very low, so you really haven't changed things very much. And you still have to have the surgical capability to take care of a whole bunch of things in general, so it really hasn't changed your medical system either. So I've never been in favor of prophylactic procedures. I just don't think they're going to really change what your medical care system needs to be.
Mark, the last question that we wanted to ask you, and again, I'll preface it with thank you so much for your time. We know how busy you are, and the Canadian audience in particular was really excited to hear from you. My question is, you've been at this game for a very long period of time, and you've seen administrations come and go, in particular in the NASA world. I'm curious what your overall view of the culture of NASA as a government-run agency sits in terms of what seems from the outside to be a bit of a freight train with Space One and SpaceX and all the sort of private / commercial entities that are moving along. Where do you see all that settling out with the roles of each side, and where is it going?
Well, it's definitely the Wild West, and a lot of the companies and entities that are around now probably won't be around 10 years from now. Yeah. So it is very chaotic and confusing. NASA itself tends to like to do things in-house, and they like to hold their cards close to their chest. And so I think it's important that if anybody is really seriously wanting to do something in space medicine, they need to get inside. They need to try to become a part of the a part of the NASA space medicine culture. And I don't know exactly what that means, if they need to find a way to get involved in research that's NASA funded, or get involved in medical operations at NASA. But they need to become a part of the NASA culture to be able to get any benefit out of it.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.